Good afternoon, everyone. I'd like to thank the course coordinators and the moderator for this afternoon session for inviting me to give this talk entitled Proton Pump Inhibitors, the Good, the Bad, and the Ugly. So it seems kind of strange to call an entire class of medications all within one sentence, good, bad, and ugly, but that's really where we are with this. I know Dr. Gasemi gave a review on this topic about 2 or 3 years ago from this podium. So my role today in the next 15 minutes is to review what's come out most recently in the last 2 or 3 years, and then just to give us a way for going forward in terms of prescribing long-term PPI therapy. I have no significant or relevant financial disclosures. So before prescribing PPI long-term to anyone, you need to really determine when is it appropriate or inappropriate. And with all the negative press that PPIs have received over the past 10, 15, almost 20 years, this group out of Italy came up with the so-called appropriate indications for long-term PPI therapy. And as I go through this list, you have to ask yourself, is there anything else we could use to treat these patients other than PPIs? So to begin with, clearly Barrett's is an indication for long-term PPI therapy. The patient with the more severe esophagitis, LA grade C or D, should and can safely be placed on long-term PPI. EOE, and in the last 2 or 3 years, the concept of PPI responsive EOE has fallen out of use. The so-called PPI trial is no longer needed, so PPIs can be chosen to treat EOE on the same footing as topical steroids or dietary elimination. Any patient with idiopathic peptic ulcer disease, that is, they're H. pylori negative or without any non-steroidal anti-inflammatories or aspirin use, they should safely be on long-term PPI therapy. And by long-term, the authors recommended more than 12 weeks, 3 months. Clearly, patients with Zollinger-Ellison should be on long-term PPI, as well as patients with so-called PPI responsive GERD or PPI responsive non-erosive reflux disease. In terms of the 2 categories that might be underused in terms of PPIs are those long-term non-steroidal anti-inflammatory users or long-term COX-2 inhibited users. They would benefit from being on long-term PPI, as well as those patients on chronic dual antiplatelet therapy, but they need to have an additional risk factor for you to decide that you'd want to continue a PPI long-term, such as age greater than 65, concomitant corticosteroid or anticoagulation use, or a history of peptic ulcer disease. And then lastly, in patients with chronic pancreatitis whose steatorrhea is refractory to enzyme replacement therapy. When is short-term PPI appropriate? Between 4 to 12 weeks in the more milder form of esophagitis LA A and B, obviously as part of H. pylori eradication in conjunction with antibiotics. A patient with functional dyspepsia, should and can safely be given PPI for between 4 to 12 weeks. Prior to endoscopy in the hospital setting, for a patient with an acute upper GI bleed, and this would be given in the intravenous formulation. And then following that initial in-hospital endoscopy for the patient with upper GI bleeding, if they have a high-risk stigmata, they should be placed on short-term PPI therapy. And then lastly, any ICU patient who is with respiratory failure or coagulopathic, they should be placed on short-term PPI therapy for stress ulcer prophylaxis. So when was it felt that chronic PPI use was not appropriate or inappropriate? Any patients who's on corticosteroids without the concomitant use of a non-steroidal anti-inflammatory. So being on prednisone alone is not an indication for being on a long-term PPI. The cirrhotic patient, not appropriate to prevent bleeding from portal hypertensive gastropathy. The only patients in the cirrhotic population would be those post-variceal banding, where you might want to give up to 10 days of PPI to prevent post-variceal banding ulceration. Patients with acute pancreatitis do not need to be on short or long-term PPI. And then patients in a regular hospital bed, not in an ICU setting, should not be given PPI for stress prophylaxis. I think this is where we as gastroenterologists have gotten ourselves into some trouble with PPIs. This group of uncertain benefits, such as those non-responsive to PPI. Clearly, if they're non-responsive to PPI, they probably shouldn't be on it, certainly long term. And then the extraesophageal group. Our practices are becoming filled with referrals for patients from these specialists, asking us to weigh in whether acid reflux can explain any of these other conditions. We receive many consults from our ENT colleagues. Patients have symptoms with hoarseness of voice, throat clearing, globus. The pulmonologists will send us patients with asthma, chronic cough, pneumonia, bronchitis. And I put a triangle there between the two, and often the patient is in the middle of that triangle. And at the 3 points is the gastroenterologist, the ENT specialist, and the pulmonologist. Cardiologists will ask us to weigh in on patients with non-cardiac or atypical chest pain. And even the dentists are asking us to look at patients with dental erosions and halitosis to see if they can be explained by acid reflux. But I think the take home for this group of patients is that they probably benefit most from some sort of pH testing, either a Bravo study or intranasal pH impedance. Here in the US, the HEA and the ACG have brought out their recommendations in terms of chronic PPI use. And on the far right, the FDA has given approval to only 4 of those indications for long-term PPI use. At the top, acid reflux and esophagitis, really you want to consider at some point doing it on an intermittent or PRN basis. As you go down the list, I mentioned the 2 areas where maybe we underusing PPIs, and those are patients who need it for, they're on chronic non-steroidals or dual antiplatelet therapy. And then at the bottom, patients with Zollinger-Ellison syndrome would need to be on often much higher dose PPI therapy than you'd suspect. Looking at this, because the PPIs have not received FDA approval for all conditions, that does not necessarily mean we cannot use it, if the indication is deemed appropriate. So PPIs have been prescribed since 1989 when the first PPI, omeprazole, came to the market. And since then, 5 other PPIs have been on the market. And since 1989, and you can see with the red dots, the number of PPI prescriptions has greatly increased over the years. And concurrent with that increase in the prescriptions were the increase in the number of articles in medical literature highlighting potential safety issues with chronic PPI use. And then the graph on the right shows that as the PPIs have been prescribed more frequently, the H2 blockers have kind of tapered off and, been prescribed way less frequently than prior to PPI being on the market. So with this availability of PPI, and because they're good and they work, there's a huge economic and financial burden with us prescribing PPI. In the US in 2015, PPIs ranked in the top 10 national health-related drug expenditure. In the US alone, PPIs may account for up to over 10 billion in healthcare costs. So there's a huge financial and economic burden. I mentioned the off-label and potential overuse of PPI therapy in one study. PPIs counted for up to 55 prevalence of off-label use in an ICU setting. And there is current evidence that PPIs are often overused with up to 25 to 70% of prescriptions having no appropriate indication. So this brings us to the ugly. So in medical literature and the media, both press and newspaper, these articles have come almost monthly as to potential associations with various conditions in patients receiving chronic PPI. Cardiac mortality was said to be increased, affecting calcium, vitamin B12, iron, magnesium absorption, increased association with strokes, chronic kidney disease, Clostridium difficile. Pretty much, you name it, there has been a study almost out there identifying some sort of negative association. And if you look at this chart, pretty much no organ system has been spared, none. Some surprising diseases you might see on that chart associated with PPI, things like cutaneous lupus, rhabdomyolysis, SIBO, and microscopic colitis. And then there's obviously the usual culprits, increased risk for CKD, dementia, osteoporosis. So these are the proposed mechanisms for the adverse effects that we see with chronic PPI use. And starting at the top and almost going clockwise. The issue with dementia is due to beta amyloid deposition as well as a potential vitamin B12 deficiency. The story with chronic kidney disease, often it's an idiosyncratic reaction leading to acute interstitial nephritis. Patients might develop severe hypomagnesemia, but those are usually patients on loop diuretics. The issue with co-administration of PPI therapy with clopidogrel felt that due to the cytochrome P450 interaction, there might be decreased clopidogrel activity, and this might lead to increased cardiovascular events. Because there's decreased gastric acid, this might result in calcium malabsorption, leading to increased risk of osteoporosis and bone fracture. There might be increased iron deficiency and vitamin B12 deficiency. And then because the stomach is now more sterile with less acid, there might be an increased risk for SIBO, traveler's diarrhea, and even C. diff. So thankfully in 2019, this study came out, and we really needed this amount of authors to really hammer home the safety of PPI therapy, especially when used long-term. So this study looked at almost 18,000 patients. They were all over 65 years of age, and they all had stable cardiovascular disease. They were randomized to receive either rivaroxaban alone, rivaroxaban plus aspirin, or aspirin alone. In addition, they were randomized to receive pantoprazole 40 milligrams or placebo. And these patients were followed up for a median time of about 3 years. So because it was primarily a cardiovascular study, the primary cardiac outcomes were that there was no significant difference between cardiovascular death, stroke, or any of the cardiac outcomes in those patients taking PPI or those who are on placebo. What about all the other usual suspects listed on the left? So if you look at all the odds ratios are extremely low. The p-values are of no significance for all the adverse outcomes except enteric infections. Enteric infection was the only outcome that had an odds ratio that did not cross 1, and it also had a significant p-value. Clostridium difficile in patients using PPIs chronically. In the pantoprazole group, there were 9 patients, in the placebo 4. So 13 patients out of 18,000 is almost of no significance. When looking at the odds ratios, you'll notice that in all these association and observation studies, the odds ratio is always really on the low side. And we have this area of bias between an odds ratio of about 0.33 and 3, where really we're not sure what to make of it. It might be susceptible to bias within the study or confounding variables. So if you read a lot of the studies highlighting issues with PPI, you'll see that the odd ratios are normally on the lower side. Dr. Hill in 1965, he was an epidemiologist. He wanted to look at cause and effect, and remember, association does not prove causation. So he took and he identified 9 criteria that might help you when looking at cause and effect. And if you apply this to PPI therapy and you go down the list, you can see that oftentimes there's no good specificity. The temporality might be off. The strength of association might be poor. And if you apply this to the studies, oftentimes they don't even report on what dose of PPI the patients were on, and really if they were on appropriate indication. So if you look at these 9 criteria, which you should do whenever looking at a cause of effect, and you apply it to all the potential adverse outcomes, you can see that there's a whole bunch of no's, and none of the studies get 9 out of 9 for association, and barely any of them even get 4 out of 9. So if there is an association, it's really on the weak side with poor evidence. What about looking at relative risk versus absolute risk? If you look at relative risk, the numbers are pretty scary, 10 to 20%, 4 times fold increase in various of these adverse outcomes. But if you really look closely, and, a parameter that you should really focus on is the absolute excess risk. And you can see that the absolute excess risk in these studies is almost negligible. So I think it's important to remember, rather concentrate on absolute risk rather than relative risk. So what is the problem with the evidence? And this is something that you can kind of discuss with your patients on an individual basis. A lot of the association studies were done retrospectively and observation. especially with the work done with osteoporosis, there was heavy reliance on ICD-9 and ICD-10 codes, and that's limited by the information that we as physicians give to the coder. As I said, there might be confounding issues in terms of what exactly was the dosage, duration, and were these patients actually compliant with their PPI therapy. A lot of the studies don't even mention the indication for the PPI, and often the use of the PPI might actually have been inappropriate. I spoke about causation versus association, and we know that association does not prove causality. Remember to concentrate on absolute risk rather than relative risk. And patients on PPIs, they're often sicker and therefore older. And this was a problem with a lot of those observational studies. The AGA in 2017 came out with a whole bunch of do's, and that's basically just try to stick to appropriate indications. Some of the don'ts are long-term PPI patients do not need to be on probiotics. They do not need to raise their intake of calcium, vitamin B12, or magnesium beyond the recommended dietary allowance. And we should not be routinely screening or monitoring bone mineral density, creatinine, magnesium, or vitamin B12. And lastly, you do not need to tailor specific formulation of PPI based on a potential risk. So where are we now in 2022 is I think we should identify all our patients who are on chronic PPI therapy, and number one, determine whether they need to be on it for appropriate reason or not. If it's an appropriate reason, it's safe to continue. If it's an inappropriate reason or the patient is receiving no benefit, then really we should push towards considering deprescribing. And what deprescribing means is try get the patient on the lowest dose that controls their symptoms, or sometimes stop and try using the PPI on a PRN basis. You can then review the patient. If their symptoms return, you can consider, dietary lifestyle modification. You can try them on alternative medicines like H2 blockers. But if their symptoms do return and they are requiring PPI therapy, then you can get them back on the PPI therapy at the lowest dose that does control their symptoms. So with that, I'd like to thank you and hand over to the next speaker. Thank you.